a 28-year-old male presents with easy frizzy for the past 6 months. Differential, you're 24, what could be? Cushing's, what about non-endo? Anemia, some kind of blood disorder. Maybe he's getting abused. I don't know. Could be abused. Could be other medication. Right. We don't know, but we know we're in endo, so it's probably not spousal stuff or anemia. So we get your history, and he has recently been administratively separated from the military for failure to meet height and weight standards. He's gained 60 pounds in the last 2 to 3 years without a significant change in dietary intake. Most weight gain has been in his abdomen.
She's talking about me.
Review systems that you do. He admits fatigue. Okay. Anemias can be
Suspicious.
Oh. Hold on. It's probably his hair. Yep. There we go. That's loud. Ooh. Too loud? Okay. All right. So, what are we thinking now? Still maybe anemia, meds, we don't know, right? But at least for the past medical history, there's no medication. So we do a physical exam. Thoughts on those vitals? High, what's high? Blood pressure.
Secondary respirations.
His BMI, that is class 3 obesity, so we confirmed the obesity.
Is his breathing labored?
We see central obesity, but he's, I guess, he's well carried. Ooh, moon face, facial plethora, buffalo hump, which is that
Hopefully testing like that.
dorsal fat pad, supraclavicular fat pad,
Paint a
large
picture for me.
purple stria on his abdomen, thighs, and axillary folds. Epilosis are
Moon
confirmed.
face. Buffalo.
Proximal muscle weakness is noted, with thin extremities, heart and lungs are good. Okay, so we're painting this very Indo classic picture, right? We're building on things from lesson 3 and lesson 5. What do you want to do now? We got a good history. We did an awesome physical exam. Labs, yes. Okay, so we go into his record, put labs, and we see, oh, he recently had labs done, like a CMP, and it showed slightly low potassium, but otherwise normal. Okay, what endo labs do you want to get? Thyroid? I like it. TSH, maybe? A1C? What else? For Cushing's. Glucose? Yeah, so repeat the CMP maybe? What for Cushing? Dexamethasone suppression test? I need 2 though, right? What's my second one? Yes, perfect. 24-hour urine cortisol, or you can do the late night salivary test. You guys are great. Oh, that's just highlighting the things. Okay, look at you. You already had that. So the overnight dexamethasone test, cortisol is high. 24-hour urine, cortisol is high. What's the diagnosis? Cushing's. Which one? We don't know. We just know that he has hypercortisolism, so Cushing's something. So what do we do to get there? Lab, rad, magic wand, ACTH, points it to the right direction, right? So our diagnosis is Cushing's syndrome or Cushing's disease. He also has obesity. He had this high blood pressure. We need to potentially work that up. We're going to get more labs. And we get, where is that? Oh, plasma ACTH, right? That's going to point the cause. It's just slowly telling us what you guys already know. Knowledge check. This again, remember those terms. ACTH dependent versus ACTH independent, right? Pituitary or ectopic versus adrenal. Okay, which is pituitary or ectopic dependent or independent? Dependent, right? Dome dependent. ACTH excess is causing it versus adrenal is independent. It's something in the adrenals causing it. There's, if you're like, I don't remember any of this, you go back, here's why, your why, okay? So, we get additional labs. ACTH is 5. So, based on the range, that is low. So, where's the problem? Yeah, because is the anterior pituitary working? Yeah, it should decrease ACTH when cortisol is high. So the problem is in the adrenal. So what do we do? How do I figure out what the problem is in these two? Yeah, we're going to do a CT. We do that, and we find a unilateral adrenal adenoma. We refer them to surgical endocrinologists for removal of that adenoma, or maybe unilateral adrenalectomy. Okay? Great job. Your first patient of the day. Next, we have Serena Zen, a 20-year-old female complaining of weakness, fatigue, poor appetite, weight loss, diarrhea, amenorrhea, lightheadedness, with standing. And this has been going on for 7 months. What's this, Cushing's? Right? See how it's different? On the test, remember, go back to your either the diagram of the man and his underwear, and how different they present, right, versus this. Okay, so no other medical problems, no meds, no supplements, doesn't smoke or drink. Is this presenting like excess cortisol? We said no. All right, so we've got a history. There's a lot going on. What are those vitals telling you? High blood tension, right? You do an orthostatic test, the tilt test, and that's positive, right? So there's a change in blood pressure, and depending on the patient's condition. When do we check orthostatics? Dehydration. Yeah, dehydration. They come in and say I'm lightheaded with changing position. Sometimes we'll do it with dizziness a lot of times. Just I want to make sure you're safe to drive home. Perfect. She's well developed, well nourished, no acute distress. Sorry, these are acronyms I guess you don't know yet. From Magno. Skin. Increased skin pigmentation is noted in a generalized pattern with darker pigmentation. What are PIPs and DIPs? Right in the hands. Okay. Palmar creases, and there's lots of axillary hair. You guys are good at your physical exams. Initial labs are ordered. You get a CBC, CMP, and a urine pregnancy. Okay. Here are what the labs show. Sodium is low. Potassium is a little high. There's some changes on the CBC, but she's not pregnant. Okay. So what do you want to do? What should we do next in ENDO? Before rats. Does this point to an endocrine disorder just with these labs? Not yet, right? When we talk about cortisol, the adrenal cortex, what hormone do you think? What do you think this person might have? What's under the Addison. What's Addison also called? Primary adrenal insufficiency. And there's that. What is secondary adrenal insufficiency? But that presents a little different, right? They don't have the hyperpigmentation. They're more that like lighter skin, alabaster. And you know what else they don't have? They don't have electrolyte abnormalities. So don't get freaked out if you're on a test or in real life you have these abnormal things. Don't forget to continue that endocrine workup. All right, what labs do we do? You want to remember? So what do we expect the cortisol to be? It's adrenal insufficiency. Low. So should we check that? Yeah. When do we check it? In the morning, right? Because of that diurnal pattern. Well, let's go ahead and check the ACTH too, right? And we also check that in the morning. Okay. So here is probable cortisol insufficiency. We're thinking primary based on physical exam and the initial labs. You get your morning cortisol, it is low. Oh, and the plasma ACTH is high. So again, just like with the Cushing's, ACTH points to the problem. Okay, so where is the problem? Cortisol is low, ACTH is high. Yeah, is the pituitary gland doing what it's supposed to be doing? Yes. So the problem is not the pituitary, it's where? Adrenal. Again, that just confirms what we already knew, right? Primary adrenal insufficiency, but we have to do more than just, maybe she had a bad spray tan or has anemia. Okay. So here you guys got it. Now what do? Endo referral. You would do. I would do imaging. We're going to refer them to endo. They can consider that cocinotropin stimulation test, right? We're going to give this person ACTH. But what do you think if we do the cocinotropin test and we give them ACTH? Does this make sense that it's low? It's very good, right? Because we're giving them ACTH. Cool, the adrenals are atrophied, right? Like, you can give me all the ACTH you want, but my adrenals, that's the problem, right? From an autoimmune disorder, I have atrophied adrenal cortex. And if you did a CT, it would just show atrophied adrenal. Primary adrenal insufficiency. Oh, I told you this. What's the etiology? What's the pathophysiology? The virus, it's an adenoma, autoimmune destruction of the cortex. Scan while you're waiting. So here, just like a summary of everything, just like, yeah, I guess a summary of this whole patient, all in one slide. And then, how do we treat this patient? We're sending them to ENDO. Yeah, we give them steroids, right? I don't care what the dose is, but usually prednisone, hydrocortisone, we give it to them because what happens if they don't have the steroids? Yeah, they die. They come into the ER and what? Acute adrenal crisis, right? Scary, scary stuff. Perfect. We need to educate them on sick day rules. We need to give them their emergency kit. Maybe they have a tattoo or a bracelet. So all of that stuff. But endocrine is going to manage these guys. So good job. Having care. Okay. All right. So we're still with her. She is the same patient from earlier. She's brought into the ER after being involved in a motor vehicle accident. She sustained significant blood trauma to her abdomen. What do you need to do immediately? Pass medical issue in the ER. Yeah, EFAST. Yep, I like that. What about endo-wise? You already know what she has. What? Primary adrenal insufficiency. Yeah, she needs emergency. So should we give her some pills? Yes. IV. We're gonna give it to her IV. IM, if that's all we had. And then, so give steroids right away, followed by a bolus, like an infusion and things like that, right? Obviously, we want to check her labs because it could be other things going on. We have blunt force trauma, but you don't delay steroids, okay? Don't delay them. Especially, hey, we know she has Addison's based on her bracelet, etc. IV fluids are important. Because what if she struggled with, right? She's blunt force trauma, she's probably hypotensive, maybe shock, loss of blood. So we got to treat that as well with our EFAST. Okay. This is, I thought I would finish this yesterday. Or no, that was very baseball. We did really good. The U.S. got the most medals this year than they have in a long time. Norway beat us. I like the Summer Olympics a lot, but it's pretty awesome. Get a chance to watch highlights. Okay, we are going to lesson 6. We're not quite done with cortisol. Yes. So, all right, check on learning. We have a 43-year-old male. Signs and symptoms consistent with hypercortisolism, which is confirmed by your initial blood test, which you guys already know. Need a nice steroid use. Plasma ACTH is low. What's the misdiagnosis? We did it as a case, now it's as a test. What do we got? High cortisol, low ACTH. If you don't know right away, we just think, okay, what does that ACTH points me in the right direction? Where's the problem? The adrenals, right? Yeah, so what letter? D or E? Let's see. What's this? Yeah. Thanks for yelling. Yes, so D. Okay, but why? Right? So we have, let's dissect it. We're going to cut out distractors. So signs and symptoms, I'm telling you you have high cortisol, right? It's been confirmed. I'm giving you the ACTH. So when we just look at the questions, you know it's Cushing's. What can you immediately get rid of? Yeah. Oops. Tuberculosis, right? And adrenal insufficiency. Okay, now we're down to the 3. Then now we have to lean on our feedback loop. Where's the problem, right? ACTH ACTH is, the pituitary is working, right? Because ACTH is low, when cortisol is high. That's supposed to be what happens. So then you can cut off out A and B. Here's your reasons why. If you don't know, you're studying. We already discussed this. Here's your reference slides. Another reference slide. And you don't have to truly memorize this. You can lose those few seconds. All right, 38-year-old female presents with fatigue, anorexia, muscle aches, and hyperpigmentation. Already my brain's going somewhere, right? Laboratory tests are significant for sodium level 132, here's your reference range. Potassium 5.4, your reference range. Which of the following is the most appropriate test to obtain next as we evaluate her for the suspected condition? It's like a third order question, right? So we have cosinotropin stimulation test, pituitary MRI, CT of adrenal glands, 24-hour urine cortisol, or a morning serum cortisol level. Do I hear E? Good job. All right, let's see why. Okay, so again, with ENDO, I can't just say fatigue, right? And you wouldn't get there, right? I have to give you a constellation of symptoms. So fatigue, anorexia, muscle aches, hyperpigmentation, we're thinking adrenal insufficiency, most likely primary, right? The electrolyte abnormalities. So immediately, what can we get rid of? Let's look at the question. What's the next best? So not confirmatory, not imaging, right? So we do labs before imaging in ENDO. So what can we get rid of? Right? Yeah, all the imaging. Cosinotropin is confirmatory. So at least we're down to 2 labs. Now which one? Which one is for adrenal insufficiency? It's not the cortisol, that's for excess. So there's your answer. That's how you got it. And then here's your reason why. And more why. Alright, this one's a long one. Okay, we got this is an iPad question. So when I was in phase 2 when I first got there, you couldn't, once you took the test, students couldn't see their answers or what they got wrong or right. It was insane. And you got that, now you can see your answers. Now we have different tests, so it's all anyway. So essentially, so sometimes they would show me the question. They're like, I couldn't give them any advice, right? But they would show it to me so we could, so at least maybe after the test we could talk about it. And I was like, these questions are so long. But the PANS and PANRIC questions are long too. So anyway, here's your eye-popping question. A 47-year-old female with a history of hypertension presents to the emergency room with a severe headache that begins suddenly 3 hours prior to arrival. She has a history of recurrent frontal headaches and has recently been treated for migraines. Today, she complains of blurry vision, dizziness, weakness, double vision, diplopia, nausea, abdominal pain, and confusion. Glad she's in the ER and not in my primary care clinic. Vital signs. Blood pressure is low. Heart rate, she's tachy. Respiration rate's 20, right at the edge. She doesn't have a fever. Sweet. Okay, there's 1 plus. Pulse is fine. Pulse ox, 98 on room air. So no sense of respiratory distress per se, except for that increased respiration rate. Neurologic exam reveals bitemporal hemianopsia, so that's the peripheral vision loss. Labs show mild hyponatremia. Normal saline is administered. We start IV on her. And a CT scan is done, the tube of truth in the ER, right? And it reveals an intracellular mass. And radiology says this person needs an MRI to see truly what it is. Which of the following is the most appropriate next step in the management of this patient? Yeah. I have no idea. Yeah, I had that last night. Because I was like, yeah, okay.
B.
So let's look. Okay, so what are they giving us? When we're in the ER, headaches. We got lots of stuff going on. Vital, so sick, not sick. Sick, right? So that can kind of help arrange it. Okay, so what can I cut from A, B, C, D, E? talked about ablation radiation, right? The radioactive scan. I talked about when we do ablation for different thyroid conditions, but is it ever like rapid? Yeah, no. And then E, yeah, that potentially I know you guys haven't had EMED, but that's not, so let's cut those out. Now, I heard somebody already want to cut A. Why? When do we give A? Yeah, and when do we give hypertonic? Yeah, but ENDO, when do we give it? Yes, so sodium. And so what condition would have low sodium due to increased fluid overload? SIADH, right? So there you go. And then this is a adrenal insufficiency type story, possibly due to some kind of adenoma, maybe pituitary apoplexy or something that's going in. So we're tying all of these lessons in together. Okay. So here we go. Oh yeah, look at E. You guys know more than you think. And I won't give you an E in my question. All right. I think this might be the last one. A 37-year-old male presents for hypertension follow-up. He was on lisinopril, and 1 month ago, you guys increased it to 40 milligrams. So he was on 20, now he's at 40. He's compliant with this medication. Over the past several visits, he's had the following readings. They're all high. Physical exam's normal. Okay. What do we see? There's a lot of labs there. That's a full CMP. Give me a second. I don't give you a full CMP on the test. Wow. What do you see?
Potassium.
Potassium. Right, so we have electrolytes. We got some kidney stuff. There's a for the ALT, AST. Those are all liver function tests. Glucose, we know that. Okay, yeah. So we see that low potassium. So hypertension, super young guy. Yeah, he's only on one med, but it's not working at all. Which of the following should you evaluate him for? Which labs should you do for someone with hypertension that's not controlled, young? Say he doesn't have a family history of high blood pressure.
B.
When do I talk about high blood pressure and potassium? So anybody want to guess? Yeah, C. PRA, rate, we're going back to our reading and the RAS feedback loop. Here's Y, and then here. So 17-hydroxyprogesterone and ACTH is that congenital adrenal hyperplasia. When do we ever do a lab for 21-hydroxylase? Not for CAH, right? Because that's the enzyme that's missing. Why 17-hydroxyprogesterone is high. Morning cortisol and cosinotropin, we don't do those at the same time. And that's for adrenal insufficiency, so they have low blood pressure. And then I would have to tell you the signs and symptoms of Cushing's. Okay, I'm not going to trick you. Well, not intentionally.
B's related, but no.
Okay, that's it.
Nothing.
For lots of reviews. Yeah.
These reviews they're not posted, are they?
No, I will post them today. I'm going to post them right now. So we have to have all of our slides to be ADA compliant because, deaf and blind active duty members we have. I don't know. Anyway, so we have, this is a UNMC rule. Anyway, so I'm going to post it, but I'll probably I'm going to fix it so it's ADA. So if I post it twice, it's all the same slide, just ADA. But I'll post it today. Yeah.
Ma'am, for case 2, for the Addisons, is it necessary to do the ACTH suppression test if we know that there's high ACTH with the plasma and low cortisol? Like, we know that it's not, we have high ACTH, it's not doing it.
Yeah, so you'll do the initial labs of cortisol and ACTH in the morning, and then you're going to send them to ENDO. ENDO will probably do the cosinotropin, but on the PANS, you just have to know that that's like that's a confirmatory test. So you as a PA won't be ordering it, but it'll still be part of the puzzle to totally confirm it. They honestly use cosinotropin more for secondary and for those people who have like medication-induced secondary. But I give it to you in both primary and secondary. But it's kind of up to ENDO if they do it. I just want you to know it's confirmatory and understood why it's low. Does that help? Okay. If not, let me know after. All right. Okay, so switching gears to medulla and MEN syndrome.
After this.
Okay, so still in the adrenals, we're going to talk about just a handful. We're going to talk about a zebra, a clinical zebra. We're going to talk about what you do when you have an incidental finding on an abdominal CT and there's like a mass on the adrenals. Great, what do you do with that? And then we're going to talk about whatever MEN is, and then summarize with some hypertension. Okay, so just a very, these are really short. So we're talking about the medulla. And the hormones involved in this are epinephrine and norepinephrine. Okay? Those are part of the autonomic nervous system, right? So this is our fight or flight, right? So parasympathetic is like how you guys are right now, but the sympathetic nervous system keeps up with test day, stress, right? Car accident, the mama bear where you have to like pick up the car to save your kid type thing, right? So sympathetic nervous system is what we're talking about here. Fight or flight. Review, like that. All right, so we saw this table before. Now we're on the left side. And right away, it's different than any other feedback loop, right? Because then right away we have the nervous system at the top. So the hypothalamus is triggered by some kind of stress. And the nervous system jumps in. So is this going to be a fast response or a slow response? It's fast, right? Fight or flight, it's in the name. The nervous system, it gets triggered and it tells the adrenals to release norepi and epinephrine, right? And it's time to get into action. We're going to have increased heart rate. Blood pressure is going to change. We're going to change the way the blood flows, right? Like I don't need to poop right now. I need the blood to my muscles so I can run or fight. So again, here's just a summary, review as far as what happens when catecholamines are released. You don't have to memorize that list, but it helps you associate it to the presentation we're going to talk about the disorder. Okay, we're going to talk about a disorder when catecholamines are in excess and why they present the way they do. Right, and then when do we normally want catecholamines to be released? When we're super hypertensive, there's a lot of blood loss, or we're really hypoglycemic, right? We have something concerning happens, severe illness, emotional stress, okay? So we need this to happen all the time, but or we need this system to work. What we're going to talk about is a disorder when it doesn't work correctly, and those catecholamines are in excess. So that's your pheochromocytoma, or a pheo for short. It's the zebra. So sometimes people will tell you common things are common, right? So it may, this one is like, I think it's like, you hear like a horse, no wait, I don't know. Anyway, you think it's usually it's a horse, but in this case it's a zebra. I have that analogy. But essentially it's super, super rare, but we can't miss this. And it's gonna be on the pants, it's fair game for that. We do guys talk about POs before this, Kat?
Cardio.
Cardio, okay. But yeah, first thing there. Perfect. We're overlapping. All right, so pheo, again, it is a neuroendocrine tumor in the where? In the adrenal medulla, right? And what it does is it is secreting excess epi and norepi, not triggered by the nervous system, right? So it's following this trend of all these other adenomas, right? It's increasing the hormone when it shouldn't be. Super rare, thankfully. There's another condition, perigangliomas. So this one is FYI, I'm not having you memorize this because this is where you have a tumor that's secreting usually norepinephrine only, and it's outside of the adrenals, okay? Usually they get in the neck or the chest, and there's a lot of cancer associated with it and that sort of thing. But again, I only need you to know about PHEOs. But both are lethal, so they can kill people, especially if it goes untreated. Death in about a third of patients prior to diagnosis. But again, it's rare. And interesting enough, sometimes they're found incidentally. So if I tell you 50% of people are found by incidental imaging, what does that mean as far as clinical presentation? Yeah, they can present really scary, or they can present asymptomatic. So let's go into that. So your classic signs and symptoms are at the top. Okay, so we're dealing with hypertension, 81%, headache, diaphoresis, and palpitations. Okay, those are your key symptoms. Other things that they'll present like is anxiety and nervousness, and it's described as a sense of doom. But if you see a patient in just a typical panic attack, they kind of have a sense of doom anyway. But do they also have diaphoresis, hypertension, headaches, severe tachycardia? So what I'm telling you with is a lot of these people are misdiagnosed with just anxiety. Okay? If you have a patient with severe anxiety, maybe you this in your differential. They'll have a tremor, weakness, fatigue because of ENDO, nausea, vomiting, abdominal pain. So they present like an acute GI sometimes, just like adrenal crisis can. Weight loss, dizziness, Raynaud's. You learned about that in PATH where the fingers go white and then purple. Relatively asymptomatic. That shouldn't be a surprise, right? Because 50% of the time, we find it incidentally. So, jumping in a little bit more, so I think I have it on this slide. Yeah, so with hypertension, it can be sustained hypertension or paroxysmal. Paroxysmal means so it's just essentially episodes. Now, these episodes can be spontaneous or they have a pattern. Okay, and so the episodes will be hypertension, which is the patient isn't going to know they're hypertensive, but they're going to feel sweaty, they're going to feel those palpitations, and their headache. Okay, so they're at least feel 3 of the 4 classic symptoms. They'll be anxious, tremor, weakness, and the episodes can happen from bending forward, from lifting things up, from exercise, emotional stress, and they can last anywhere between 10 and 60 minutes. That sucks, right? 60 minutes of that. I would hope someone would come in. But maybe 10 minutes, they might dismiss it as like, okay, I was just under stress. It was a 10-minute episode. It's probably anxiety. And you can see how it can be mixed, right? Medication can cause this too. So this, there used to be a list. I made it as a table, just so you know. I'm not going to be like, what medicine causes a pheo, right? If I add a medicine, it's part of the story. This is ENDO. There's a lot to learn. So I won't do the nuances of pharmacology. But these meds kind of make sense, right? Amphetamines, cocaine, decongestants can cause a lot of cardiovascular stuff. IV contrast is a big one. So when do we give IV contrast?
Imaging.
Imaging, right? Yeah, so that's going to be, maybe keep that. The last thing I want to do is give someone IV contrast, have them have one of these events in the CT scan, right? And then surgery. Surgery is a really, the general anesthesia and just the surgery itself can flare or cause these episodes. Okay. So there's also a hypertension crisis. So they can present in this extreme, super sick, catastrophic presentation. So hypertensive crisis, their blood pressure is really high. They have significant arrhythmias. And maybe these are triggered because of the contrast threat, dye, anesthesia, a surgical procedure, or even a vaginal delivery. So again, significant stress on the body can cause it. FYI at the bottom. This essentially goes with everything fails, all organ failure when you're in this hypertensive crisis. And this will tie this back into treatment. All right, so labs. The first one should make sense, right? If I have a patient who has headaches, hypertension, they're tachycardic, they're losing weight, TSH in 3, T4, maybe even T3, right? For that hyperthyroid state, CBC, I want to check for inflammation, I want to see if their electrolytes are off, are they hypoglycemic, hyperglycemic, where this will help with the differential. Well, what I need you to know, when you think pheo, whether it's in clinic or on a test, these labs, we're going to actually go and order plasma fractioned metanephrines to check the ketocholamiine levels, okay? So it's the best ideal test to check and rule out a pheo. So if they're normal, Move on to the other differential. If they're high, now where's Theo? Now we need to work it up. Confirmation. So the blood tests are your initial tests. If those are high, you can do a 24-hour urine to help confirm the diagnosis. Genetic testing. Because a lot of times they don't just have a theta, they have other issues too, so that's a piece. But the big thing here is plasma fractionated free metanephrines. The 24-hour urine is confirmatory. You guys kind of get this right here. It helps with the diagnosis, but I'm not going to expect you to put that whole list at this point in your career or phase 1 career. All right, imaging. We did our labs. Our labs show positive, so we have free metanephrines that are high. Let's go to a CT, right? Because where's the problem? The adrenals. So non-contrast CT. Why?
Wash it out.
The IV contrast sets it up. Again, CT is annoying as it is in this tiny little thing, and then we put them into like a hypertensive crisis. No, thank you. Now, current says no contrast CT. There you will see people who have theos who get it and with IV contrast. But again, no contrast is the goal. If they can't, you could have a CT for whatever reasons. You can do an MRI. The sensitivity of catching a theo with an MRI and a CT is 95%. Okay, that's just you with stuff. So if the CT isn't clear, you would order an MRI. What I need you to know is the top one. Okay? Which is nice because it's always adrenal CT. When it's adrenal problem, what do we always order? CT. Okay. So treatment. How do you think we treat these people? Surgery, meds, radiation, what do you think? So if I say that there's a lot of risk for cancer, a third of these people die before diagnosis. It's pretty treatment's pretty important, right? So it's surgical. So we're gonna go at the bottom first. Surgery is the treatment of choice. And it's everybody and their mom is in the OR, right? Endocrine's in there, anesthesia, neurology, a general surgeon. If you get a theo, everybody wants to kind of go see that. And they're on standby, right? Because just giving them IV sedation can set them off into an episode, right? So lots of monitoring. But again, we have, they might not, if they present just with these mild episodes and they're not in hypertensive crisis, they might not have the surgery right away. So that's when we pop up here. And we need to manage their hypertension, all right? Manage their tachycardia. So we want to prevent what? Hypertensive crisis, okay? So to do this, did cards teach you about that a little bit? Okay, so you need to do an alpha blockade first. And that's either with an alpha blocker or a calcium channel blocker, right? So your OSINs or your nifedipine is the example I have there. So either one of those have to happen first. Because we need to block the effect of norepi on the blood vessels. And that's to avoid an unimposed alpha-adrenergic stimulation, right? We're preventing hypertension crisis. So I can't give them a beta blocker first because we need the alpha blockade. So it's A or C, or A and C before B. Yeah. Does that make sense? You understand the why, right? It's all right here. So A and C before your beta blocker. And if they feel fine on doxycycline, then you're good. But if they're still struggling with the tremor or the blood pressure is still hard to manage, then you can add the beta blocker only after. So know the order, okay? Because that's important. If they are asymptomatic, then we would just really educate them. We don't necessarily need to throw an alpha blocker at them. But again, that would be a phone call with ENDO. Here's a 3-centimeter theo. Jingles aren't that big. Yeah, so that's no good. Surgical removal. And again, what are you involved in potentially is that the pre-op hypertension management, and then just understanding that they are monitoring these people during the OR, after the OR, because of the hypertension crisis risk. So prognosis, if they catch it, they do okay, but it depends on a lot of factors, right? So a lot of people with PHEAs, they have a risk of cancer and metastasis, but the annoying part is so say we diagnose them at 25, we have the surgery at 25, that cancer and those mets, the metastases might not show up for another 5 years. So they're monitored really, really closely. 25% of them will still have high blood pressure that has to be managed. But just again, it's prognosis varies. All right, we will take a break and then we'll go into whatever multiple neoplasma are. When you guys get back.
The ocean, you know, with here.
What?
She's gonna go tell him to turn the heater more up.
My bladder.
Yeah. I'll tell you this. Diabetes. You got it. Let's go. Because we don't know shit. Thank you, baby. We thought you sat here and studied it all. Oh, no. Oh, no, yeah. Oh, that shit. Oh, and then it hurt. Yeah. Like 2 hours. Maybe it's. Yeah.
The way that you explained it to me yesterday,
Yeah.
oh yeah? I'm not necessarily worried about it, I just wanted to make sure that
I know, you're like, I sleep agree because you're broken. Yeah. That's right. Real life is not. Why?
I don't know if it's like cold morning. I don't know if that's probably cold morning and then it's like knees.
at one point when I started saying,
Don't do it.
Or it's just funny that
And ENDO does it, you do it for a second.
I just know that.
So I fall
So you
over,
don't
break my
fall.
nose.
Don't fall. I'm not trying to have you avoid it.
Secondary process.
You can do it.
What? Yeah, but I.
Sounds about right.
Also, like, every year, like, you don't every voice.
Okay.
I miss fishing.
Just right. Like if you get something, they would delay you. They would just cut. They would.
Try to delay.
I think it was deleted. But then again, like you wouldn't know until you report. That's a lot of enterprise.
Where are you going?
So here's the meta question: is that
Oh no,
so the report date's in July, not last year.
yeah, but it's report date.
His new state is in July. Here's the thing: that no, but you think of that.
But it's
No, you get accepted. They get accepted soon, right? You have to now, after you get accepted, get your range. Ranch would say no. No, the commander's go before. No. You get what? After you get commander, you get range. After you get accepted, you get range. Rank is something different.
I thought you still get the commander at the end too.
No, I mean, rank is something say no.
But if you already accepted,
Yeah.
why would range say no?
Because they can, because
Whoa.
this guy's on orders, like if you go somewhere else in July, that's that's the difference. So like he's immediately PCS and then PCS for the rest of the year. That's what
That's the last cohort, which is the report date.
well, I would just defer the orders. Like that's just the easiest stuff. Well, I would do it 90 days just to see if you get in. If you don't get in, you still have to report this next year. If you defer for 90 days and then you get in, then you can have the branch and be like, okay, we're gonna leave those orders. Wait, put it right now.
Yeah.
Because in theory, he can get accepted to the January date, and then he just leaves in November. No, that's something like that. Like, how like a dilemma and
Sometimes you ask stupid questions.
he's like, I'm guessing until
You give out orders.
and then all last time they're getting like I was saying like it'd be the first 90 days and then second
What's crazy? Giving someone a report date like in like
Just call ranch and
Yeah.
ask. Like, that's a whole solid. Like,
I don't know if you recall as a normal medic, like 5 months.
I get online. I chat with them. They're always on
yeah,
chat.
it depends. Like, if you email the actual brand or you email your like, the place for range. They
Yeah.
have, like,
You
certain.
can email the branch chief and they can tell you,
Yeah.
they can tell you F off. And then
When I just spoke to her and she likes sign notice. Like I literally attached the
that is different. That is different Well, that is the thing. If you're sort of calling the entire branch and hey, I want to change
Well, I
my
didn't mean, I meant branch, like like with attached to the branch. You're supposed to call it branch.
It has to be a fun, like I said.
The man.
But like I said, have you ever tried calling a branch? That's normally fun. It's not. Exactly, that's what I'm saying. It's not easy. It's easier when it's not.
Yeah, that's what I'm saying.
It's not easy. You know,
You don't have to yell at me.
I'm telling you how it is.
Gaslight.
You say it as if it's easy task. It isn't.
It's easy.
It takes time. If you
You're not listening. How do you talk to someone that doesn't answer? That's what I'm saying.
Not the branch chief.
I'm literally talking to the
We are.
No, you're not.
He said, go talk.
Have I said?
Well,
Have you
jump into this.
tried?
Next topic.
How it
Are you
is.
guys seeing Teams pop up on your end? No? Okay, I have, apparently there's a Teams that keeps popping up, and I didn't want to distract you, but you guys don't see it, so it's getting to distract me. Okay, so, multiple endocrine neoplasma, or we call it MEN, or MENS, there's 4 of them, and it's listed on the pants. It ties in some of the conditions we've already learned about, luckily. I will go through each condition, stay with me, and then when we get to the summary of them, I'll be very clear of the extent. Okay. But essentially what they are, they're hereditary tumor syndromes with distinct patterns of organ involvement. So again, someone super smart found that there's these, either based on family history or personal history, due to germline tumors, they have similarities in their tumors. Okay, so see what I mean. Okay, so again, hereditary tumor syndromes with distinct pattern of organ involvement based on a personal and family history. Yeah, good time. Okay. All right. So again, from the syndromes, at least, so it's not going to be just a pheo. It's going to be a pheo plus thyroid cancer plus pancreatic tumor, right? Plus all of these things. So again, it's multiple endocrine gland involvement, and the involvement is negative, right? It's a condition causing a problem. Genetic factor, their germline mutations, if you care about that stuff. But we're going to look at each one of these individually. There was 3, and now there's 4. Yay. Here's a table from Current that essentially lists the type of tumor and which MEN has that. So there's some overlap, especially if you look at 2 and 3. All right, so jumping into MEN1. This is the most common one out of the 4, and a lot of times they present with hypercalcemia. So you check calcium with a CMP or a BMP, and then why is there calcium high? Usually the underlying cause of this is hyperparathyroidism, so parathyroid problem. But it varies, right? I told you that it's multiple endocrine glands are involved, so they could present with high calcium or they could present with something else depending on what other endocrine disorder they have. So that's what it means when symptoms are variable, but I'm going to use very classic symptoms, okay? And the treatment for this would be to remove whatever adenoma is going on and treat that hypercalcemia. So here is your kind of star on this slide. This is what you're going to see. So hyperparathyroidism in 95%. So again, that's why you're going to see hypercalcemia. That hyperactive parathyroid kicks out too much calcium. Okay. They're also they might have facial angiofibromas. I added a picture. That gentleman has it. They're these like small flesh-colored papules. So that means they're a raised dome papule. They're small, and they're usually on the face there. You can see it on his nose and his cheeks. Pancreatic adenoma, pituitary adenomas. They can have a gastronoma, insulinoma, and adrenal adenoma or hyperplasia. So I underlined the things that we've already talked about, right? So lots of adenomas. Once we get through all of them, we'll kind of compare and figure out how you will remember this. So straight into MEN2. These ones, MEN2 and 3 overlap a lot, and the big factor in both of them is medullary thyroid cancer. So rewind to the thyroid election. We talked about cancer. There's papillary, follicular, and then the third most common is medullary thyroid cancer. It's more aggressive than the first two. So for sure, how do we treat all thyroid cancer? We cut it, yeah, not the neck, cut it out, yeah. So we remove the thyroid, right? These are more aggressive, so this is scary. So if you diagnose medullary thyroid cancer, you have to also screen them for a PHEO, do some genetic testing. Do they have hyperparathyroidism? Hirschsprung, is that if you're there? Yeah, in GI, it's like a congenital condition where there's a lack of nerve cells. So if you have any baby who has Hirschsprung's, you think they're going to be screened later on in life. For MEN, again, that's why this one sometimes is taught earlier. And then treatment, prophylactic thyroidectomy. So say that you diagnose someone with MEN2 based on their PHEO and their hyperparathyroidism or family history. A lot of times they'll remove the thyroid early, okay, before the medullary thyroid cancer develops, because that risk of medullary thyroid cancer is so high. Okay? And then again at the bottom, no GLP-1s for anybody with medullary thyroid cancer or pancreatitis. All right, MEN3. So this one we have medullary thyroid cancer again, but you also have mucosal neuromas, GI neuromas. What's Marfan's like haptics? Yeah, they're really tall, they're long, they got big hands. Maybe worry about their heart. Because maybe some heart issues, organ issues, right? But they're big, they're tall, big hands, long arms. So they have skeletal abnormalities like they're related to the Marfan's, and then PHEOs again. You know what PHEOs are? And then again, early prophylaxis, thyroidectomy if we catch it in someone who presents more with the Marfan's and PHEO. Stay with me. The last one. This one is very similar to one in that it's the P's, the parathyroid adenoma, the pancreatic tumor, the pituitary adenoma, the adrenal adenoma. But what makes this different is these cancers at the bottom. So if I'm going to give you a MEN4, I have to add something to differentiate it from MEN1. And that's going to be some kind of GU tumor or cancer. Okay, these are all GU related. If that helps you remember. So when I started teaching this, you guys know I don't like memorizing because I'm old and my body, my brain, if I memorize something, I'm going to lose something important. So, but this is just, you got to do. There's going to be one question on MENs. It's going to be, here's the patient's signs and symptoms. What's the most likely diagnosis? Okay? I don't care about treatment. I don't care about that stuff. So how are you going to differentiate between this? Well, you guys probably have you're younger than me. You can memorize it. Great. Or maybe you have a little nuance or mnemonic. Do that. So how my brain works is MEN2 and MEN3 are very different. Or sorry, very similar, right? Medullary thyroid cancer. So if I tell you they have medullary thyroid cancer, sweet, 50%, I'm down there. But look at MEN3. You have mucosal neuromas, medullary thyroid cancer, and Marfan-like habitus. So 3 M's. 3 M kind of looks like an M. I don't know. And so, right, so if I have this with 3 M's, then boom, it's 3. If I have medullary thyroid cancer and there's no 3 M's, then boom, it's 2. Okay? And then same with 1 and 2, it's a lot of P's. Parathyroid, pancreatic, pituitary, adrenal. But what's different? Oh, the hypercalcemia and these adenomas on their face, angiofibromas on their face. And then the cancer, right? The GU cancer or tumors. There's a diagram. They don't have a lot of pictures on MEN4. There's that if you're a visual person. That helps. Okay. All right, that's it for MENs. Okay. Adrenal incidentalloma. Okay. So this is a fun incidentalloma. It's a fun word, right? But it tells you exactly what's going on. What does this patient present like? Like they have, so what most commonly is either you order the CT or the ER ordered the CT because the ER loves that tube of truth, right? And they order it, and the patient's fine, but have an incidental finding of an adenoma on the CT. Guess who manages that? Is it the ER? No, that's the benefit. Life limber, I say the patient's stable. All right, off you go to your PCM, follow up on this adenoma, okay? Or it's you who catch it because you're ordering a CT for something, like kidney stones or something, and they catch the adenoma. As a PCM, CTs are great. Man, there's a lot of incidental findings with CTs, liver, kidney, all that stuff. We're only talking about adrenal incidentalomas, okay? So this should be pretty straightforward. Sometimes they're asymptomatic, like if you didn't have a CT, you didn't know they exist. What does that tell me? Are these always functioning? Are they always symptomatic? No, many are non-functioning. And then, we catch them by CTs. So non-functioning, or secrete, or maybe cancer cyst. Okay, so we get the patient, they come in, and like, I have a CT, show this adenoma. I was told to come follow up with my PCM. So differential, I have to think of all these things. You know this, right? You know the top three, right? Cortisol, aldosterone producing, we know that. Non-functioning, Theo, we know that now. What tool do I use to decide which rule some of these out? Most likely it's going to be non-functioning, but what tools do I use? Yeah, labs, get good history, physical exam, labs. And you know all the labs, so we're not actually teaching you anything new. Right? So, again, physical exam. Were we looking for signs and symptoms of hypercortisolism? Refractory hypertension on a bunch of meds, young age. What else? Sophia, the paroxysmal hypertension system. Acromegaly, or do they have the facial features of acromegaly? Or do they have signs and symptoms of thyroid disease, right? More likely hyper will have hypertension, but hypo will as well. So again, we're thinking these things, so the labs are all pretty much pituitary and adrenal labs, all at one time. Just do all the labs. You know these, right? The last one we just learned about, right? Plasma fraction-free medinephrines. We just learned about the medinephrines. We already know about ACTH, DHEAS, one day, cortisol, PRA, aldosterone, right? And then imaging, CT scan was already completed, right? So check that box. Does that make sense? There's really nothing to memorize because you already know it. Treatment, observation versus surgical resection. So really the take home here is the size and maybe the suspicious in age, right? So again, it's the size. So if if we do all the adrenal workup and everything is normal, that's where we're at, okay? So when we do the adrenal workup, there was no Cushing's, there was no Theo, everything was ruled out, right? So we have a non-functioning adenoma based on our reassuring lab workup. Okay. Now we look at the size. If it's less than 4 centimeters, we're just going to observe. And how we're going to do that is they're going to come and see you and do a physical exam so you can get a history, you can examine them, you're going to talk to them, and then you're going to do CTs at 6 months and 12 months. If everything stays fine, then you would go to annually for the next few years. So observation involves what? Physical exam and CT scans. Now, when do we say, nope, I'm sending them to the surgical endocrinologist? When it's over 4 centimeters, right? Even if it's not functioning. Is that size? How big are those adrenals? Not very big, right? The bigger adeno is already 4 centimeters. It's going to maybe cause some problems with function as it gets bigger. Also, caveat, if it's less than 4 centimeters and suspicious in a young patient, you would send them to ENDO. I think that's kind of concept. There's your exception to the 4 centimeter rule. All right. Endocrine hypertension. Luckily, we know this already, and it turns out it overlaps with Friday a little bit. We saw a lot of hypertension, right? Acromegaly, Cushing, thyroid, Theos. So what are red flags for secondary hypertension? Right? What do most people have? You have a 52-year-old male, he has elevated blood pressure. What does he most likely have? Essential hypertension, right? I don't know if it's 90 or 95, but good odds that he has hypertension, and maybe he smokes, maybe he has a family history, maybe he has obesity, he's diabetes, all these sleep apnea, et cetera, et cetera. But when do we get suspicious that it's not essential hypertension? The first one, hypokalemia. What's that going to tell me? 40% of patients who have hypertension and their potassium is low, maybe it's an aldosterone issue, right? If they started at an early age, they're in their 30s or 20s, and no family history. The new one, the new presentation of hypertension in patients over 50. That by itself, every time I take this, I'm like, oh, that's like every day at USAPA that existed. But anyway, so that's, I probably won't put that if I test you on anything that I didn't take that one. Oh, resistant to maximum doses, right? So if you're on 3 medications and it's still not treating it, that's not good. If it's super severe, I know for the hyperaldosteronism, if it's like over 150 over 100 multiple times, that's a trigger for high aldosterone. It was well controlled for a while, and then boom, not anymore. That's concerning. What changed, right? Maybe there's a secondary cause. Paroxysmal, what's that? What's that concern for? Paroxysmal hypertension. PO, yes, PO, that's what you said. Absence of obesity. Okay, thin people can have hypertension. They can. But obesity is a risk factor for various things, including hypertension. And then signs and symptoms consistent with an endocrine disorder, right? You guys know all those things. So there's other causes, right? Coarctation, some renal issues can cause secondary glycogen. All of those, sleep apnea. No, I hear about the endo causes. So most common is hyperaldosteronism. We know that. PO is on there. Cushing's, either disease or syndrome, because that excess cortisol, right, causes them a lot of problems. Acromegaly, they can present with hypertension and keep that hypertension after treatment. And then thyroid dysfunction, hypo and hyper. And we haven't talked about hypercalcemia yet. But lots of, so it's like in the back of your mind, but again, most of the time, it's just essential hypertension. So this is just to kind of like tie it all back to, she's mentioned high blood pressure a lot, and then we're just tying it all in. These labs, you guys know. So maybe after you're studying, if you want to use this chart, it can help you test yourself. But again, we're going to treat the underlying cause of secondary hypertension if we can. I think we need to know that for all of these except for the calcium, right? How do we treat the underlying endocrine issue, right? You just add that on here, studying or whatever. Okay, so that's it for this one. We're going to go through cases and we're going to go through questions so that that's all done for before the review and everything, so you just post everything. But look at all you know. You know all this. You might not think you do right now, but you guys know this. All the things, the hormones, the glands, over secretion. You know the labs, you know how they present. You might know the treatment somewhere in that brain of yours, but you won't know it by next Friday. Okay. Clinical correlation for adrenal medulla. First patient of the day. What do you see? Sick, not sick? Adrenaline delete. What do you think?
Headache.
Initial, headache, right? Is she sick, not sick? I mean, maybe you need to dim the lights for her. She looks stable-ish, right? What else? So headache. She's breathing okay, maybe. All right, let's get a little bit more. 37-year-old female, recurrent episodes of palpitations, headache, excessive sweating for 5 months. Past medical history is normal. Family history is unknown. She's adopted. Does not smoke. Does not drink. What do you think that blood pressure? High, yeah. Right? 160 over 10. Slightly tachy, bless you. Respiration rates on that high end. Oh, but no temperature. Okay. There's some recent labs to look at. But before we look at those labs, what's the problem? What do we have to investigate? What's the problem? It's not the diagnosis. What are her problems we need to solve? Blood pressure, what she came in for, right? These episodic things. Palpitation, headaches. Is it hyperhidrosis? I don't know. Is it diaphoresis? Okay. So I guess the rest of the physical exam is normal. let's look at those labs. Oh, nope, I lied. What labs do you want to do? So we'll say that these were, oh, sorry, they're within normal limits. That's my bad acronym. Within normal, so her recent labs were fine. So that tells me it's not a thyroid, it's not an electrolyte issue. Now what labs do you want to do after your normal physical exam? Plasma epinephrine, very good. And you get them, and they're high. You can consider a confirmatory test that's 24-hour urine. Perfect. It also is high. Now what do you want to do? We got our physical, our history, our labs. What's next? CT. What kind of where? Non-contrast. Where? Right? Well, what those adrenals. Perfect. And sure enough, there's a 3 centimeter right adrenal mass. So what's the diagnosis? Theo. How do we treat it? Alpha. Yeah, we take it out. Before we take it out, what do we do? Alpha blockade with which medication? Zosyn, the calcium channel blocker, right? What about beta blocker? She has anxious palpitations. Not until after.
Ma'am, does it matter the beta blocker itself? I know you gave an example on one, but is it just any beta blocker?
Just use the example. I can't remember what I even gave. Metoprolol. Yeah. Thank you. Hypertension management, right? They're monitoring, and then remember that? Maybe we need to rule out MENs, right? So the Theos, so MEN2, MEN3, right? Medullary thyroid cancer, things like that. We need to rule out. We're tying it all in. Great job. Okay, cerebellum. Oh wait, here she is. Or cerebellum. What do you notice? Yeah, got a nice shiner with a gash or abrasion. She's alert and oriented. Yeah, okay, let's find out what's going on with her. So, 64-year-old female. This is pretty good for 64. Okay, involved in a motor vehicle accident, broader TDR. Has medical history, she has high blood pressure, she's on hydrochlorothiazide, no family history, denies tobacco use or alcohol. Okay. Work her up in the ER. Here's her oh yay, not hypertension. Okay. Physical exam's normal. Besides her gash, so they treat her gash, her abrasion. They do a CT scan because she was in a car accident, and they find a 3.1 centimeter adrenal mass. And so they say, hey, we took care of you. I think you're going to be okay. Here's some pain meds, etc., rest ice, all that stuff. But you were diagnosed with the right adrenal incidentalloma, clear PCM. That's nice. Yay. What do you want to do? She comes in to see you. Yeah, but before we do the CT, what do we need to do first? Always an endo. Labs. Which labs? All the labs, the pituitary and adrenal labs, right? Perfect. So, additional labs, and do them all, and they're all normal. Cool. Now what do we do? 6, 12, and then annual, right? And we have to see her come in. We have to ask her those questions, signs and symptoms of any of these issues. Perfect. And again, when we do surgery, the reason why we're doing observing is because the size, non-functioning, benign appearing, and she's over 40 years old. Okay, neonatal. There's neonatal.
That's a big baby.
All right, how does he look? Sick, not sick?
Not so.
No, it's fine, yay. You have a doppelganger? Okay. All right, 28-year-old male presents for routine hypertension follow-up appointment. He feels okay, except for he's still having headaches. Has medical history, hypertension for 2 years. Social history, nobody smokes or drinks. Medication, lisinopril, 40 milligrams, atenolol, 25 milligrams. Family history, dad had blood pressure at 58. Okay? Should we do a physical on him? Yeah, let's do that. 168 over 110. Check it twice, check it 3 times, it's still high. home records reflect the same, right? So this guy's so compliant, he's checking his blood pressure out. And it's still high. Heart rate's good, respiration rate's good. You do an eye exam, right? You need to check that, heart, lungs, all of that. Looks good. GI. Now what do you want to do? Did a physical exam, labs. What labs? Yeah. So we want to do the renin test. What like a CMP, BMP, that stuff, right? So we do our initial labs, and those come back the same day. What do you see? Now the PRA. What else besides that? What else do you want to check? What's the problem with this guy, you think? Aldosterone. So what labs do we check? The renin, the PRA for the renin. What else? Yeah, the 24-hour, that's what helps with confirmation. Well, if his aldosterone is high, should I just check that? Yeah, let's check that too. Okay. So, problem list. Did you know that? We do the aldosterone, the PRA is like, where's the problem? Is it the RAS system? Is it the adrenals, the pituitary? Where's the problem? So if aldosterone is high, should the renin be low? Yes. So the feedback loop is working, so where's the problem? In the adrenals, right, there's autonomous production of aldosterone that's not triggered by the renin or the RAS system, right? Independent of the RAS feedback loop. So the problem is in the adrenal, hyperaldosteronism. All right, so what should we do? Got labs. We think it's hyperaldosteronism. Let's get a CT scan. Yeah? What could the CT possibly show? Hyperplasia or an adenoma, right? Just like with ACTH independent hypercortisolism, right? So we get it. Abdominal CT, we send him to ENDO or internal medicine. We can consider that 24-hour that I heard. And again, it's unregulated aldosterone secretion from the adrenals. Okay, and again, it's either an adenoma or it's a bilateral hyperplasia. How do we treat unilateral adenoma? Surgery, yeah. What are these people at risk for? A lot more cardiovascular risk complications, right? We can give them spironolactone too, right? Especially for that for the bilateral hyperplasia. I want to keep those adrenals. They're important, turns out. So then that's when we would do spironolactone. All right. A 41-year-old male presents with elevated blood pressure. What are the classic clinical presentations for a female? Okay, I heard B. Great job. We just learned it. It's fresh. It's very unique, right? Sometimes those will be paroxysmal, or they could be, you could have hypertension all the time. And then that's the reason why. So A is your hyperthyroidism. C is just a mix of things, like, and then same with D. And then E is your hypothyroidism. Did not get tricked. Okay, perfect. Here's the reason why. And again, you understand why these people are often told they just have anxiety. Okay, a 32-year-old female presents with a personal and family history of medullary thyroid carcinoma. On exam, she has mucosal neuromas on her lips and tongue, Marfan body habitus, and imaging reveals a pheochromocytoma. Which of the following neoplastic syndrome is the most likely diagnosis? So there were crap. I wasn't paying attention. Told me the tricks, but I'm not studying for that. I didn't have cards on my brain. So there were two that have any medullary thyroid cancer. Which ones were they? 2 and 3. So we're down to that. And then what else? How do I decide between 2 and 3? You know, Marfan's, right? The 3 N's, or you're just smarter than me. Brain silly thing. Cool. Okay. Olympics. You guys should watch you both won an overtime. It's really exciting. My grandma was not a normal grandma, and she was like a big hockey fan. So anytime I see hockey, I think of her. But that's it. So I will post all of the questions clinical stuff for you to study next week. And then I'm doing, usually I do the review and then the case studies, but because my test is so far away, I'm gonna do the case studies tomorrow and review after. Okay, so I'll see you in the morning.